Sanjay, thank you very much, Sanjay, Dr. Balla, Dr. Ajay, Dr. Agini. I am going to speak to you on the rock hard cataract, and here I want to tell you that my financial disclosure is nil, and I want that this is me versus me. That is, I should do SICS or I should do FACO. That is what I always feel, and that is what I am going to present to you. Next. So this there are the challenges. Now, when there are the challenges, what are the challenges? A capsule cannot be seen. No glow for the axis. Weak jonular support is there. More endothelial damage can happen. A difficult trenching eye. And all these things are there. There is a and because of that, I think we should now think in this term that yes, the Phacoemulsification or the SICs. What is your choice? So that we'll have to think. And now see small incision cataract surgery. If we are going to do it, then the Blumenthal who taught me the surgery, I went to him to learn the surgery in 1996. I was with him for near about you can say the 1 month, and he taught me surgery there. So here it is a basic thing is the sclerocorneal self-filling incision. Then less learning curve is there, connect curve is there, less low cost procedure. There is no cost, less machine dependent, less damaging to the endothelium. Next. Now here you will see the what I am doing is removing the from the 5 to 6 millimeter tunnel. I am removing the 10 to 11 millimeter of the lens. That is what is there in the SICS. And see in SICS. So if you see the phaco, we have different types of you can say techniques, but here the visco expression, Blumenthal, Phacoemulsification, snare. So these wire vectors, all these things are together in the at this juncture, and so that all types of SICs can be done there. Now, what I want to tell you, how to do it. So funnel shaped incision is there, and this funnel shaped incision, uh, this is a larger one. The lens is larger one. We are removing it from the funnel shaped incision. Now the next. Now see this is essential steps are safe. The CCC, pre-nucleus, and the like the phaco only the tunnel is the difference. Now see, this is the hard cataract, and you can see this is the like an both. That is the cortical and the nuclear cataract together. Now you will see what I am doing is the incision in the always in the I do in the sclera well the blackness of the limbus ends and the pockets. So very integral part of the surgery is a pocket, and I'm making the pocket. You will see here the rexis. Now it is not must that rexis should be done, but yes, the rexis nowadays I do the rexis. Now this is the old video. So here again you will see the uh, this is the tunnel funnel. So now see, whenever you are making the pockets, pockets are very important. And here I have made the pockets, and then there is hydrodixation. And in the hydrodixation, what I will do, I will just bring the nucleus in the. Now you will see very large nucleus, also the hypermature calcified cataract here. And now I am just removing it with the, I can say the glide. The glide. Now this is a use and throw glide. See here, the nucleus is coming out, and here you can see the cortex also has came out. So this is done whenever I am doing this such type of cataract. Now this difference between SSS and phaco is for the hard cataract. Phaco you will have to like you can say, and here you will have to remove. So phacoemulsification. See here also advantages are definitely there. Incision is very small. The astigmatism is less. Recovery of this is you can say the is earlier. The recovery is earlier. Now how you manage? There are so many machines. It is not required that you should have a good machine and all other. Even basic machine can work for the hard phacoemulsification. Now here you will see the what I am doing is the trench. See, whenever you are doing the phacoemulsification in the hard cataract, the trench should not be only the tip breadth, but slightly more. So here you will see I am just removing from the side this one, and the trench is more. Now once this trench is more, then I will have to go near about 3/4 deep in the center and also in the periphery. So again you will see when that is done, And then after doing the trans properly, you will have to separate it. So here I am separating the nucleus. Yes, here you can see the, as it is a, you can say like a drill. So like that, it is a very hard cataract, and you can use burst and hyperpulse mode. Here you can see now. Again, the I'm going inside on one corner on one side, and the other side my chopper is helping, and you will see the posterior fibers. These posterior fibers are rubbery, leathery fibers, and that you will have to separate. Now, what happens here? If you are separating is too large, it means separation is if too big. What happens? It stretches the zonules, and there is a PCTR. So you must know that how to separate. See again here, the separation. Yes, you must see like V. Now, and this should not be larger, which will give rise a U. So that is what is done, and then separate on the other side. Here you will see again the fibers are always there in the
हेलो
posterior side, and these
हेलो
fibers.
हेलो हाँ मैं डॉक्टर भल्ला बोल रहा हूँ.
Now see here again the case. You can see what I am doing is now he in my this one I am chopping it. See here, my tip is going in. See, and then I am chopping. So once the tip goes inside, then you can see this. This is the vertical chop I'm making. But whenever the tip goes in, you will have to fix it. And that time, see here, you are in the vacuum mode. And once you are in the vacuum mode, then again you can separate it. You can see on this side, the vacuum is increased to 500 to you can say more than 500. Here again you will see it is a 650, 780, 88 like that, 791. So the vacuum is increased. Now see the another this one. The whenever you are making the comparison, now see here, I'm doing the on left side it is a SIs. It is just a comparison. Right side I am doing a Phacoemulsification. Now when I am doing this, what happens here? You will see the I'm separating here. Now see, Phaco is always better than SICS result wise. But whenever you are planning, and if you know that yes, you can do the Phaco also, there is no problem. But where you feel that this Phaco, you should not do it, in or you can have some alternative. That time you can definitely think that yes. Now ball out each other. Now what happens? The wide subluxated cataract here I am doing, and on other side you will see the other type of cataract here. What you see that I am doing. Can you see this? So two cataracts I am doing, and can see here how now here I am using the ring. Just now you have seen the subluxated cataract. Now here what happens? I have done a small axis, and I am doing the SICS. So what I am doing? I am doing the Phaco so that the pieces of the nucleus will be smaller one, and so that I will remove the pieces from the SICS. It means the Phaco is helping me in the SICS. Now here you will see I was doing the Phacoemulsification, but there was a PCTR. Now the SICS is helping me in the Phacoemulsification. So here you will see this SICS has helped me, and I'm removing the pieces instead of those which are going behind. So SICS or Phaco, that you should decide, and this is a combination work best as the two techniques complementary to each other. It is not a different techniques; they are complementary to each other, and so these techniques works better. And I think if you are master in the both the techniques, that is always helpful. So thank you very much. I think this is what I want to say.
Thank you, Lahane sir.